All right, well, we're almost there. We're still talking about imbalances of the most important electrolytes, and I'm focusing in this lecture just on sodium and potassium. We talked a little bit about sodium. We know that when sodium is low, that will cause the release of aldosterone. Aldosterone will command the distal convoluted tubule and proximal convoluted tubule to reabsorb sodium. When more sodium stays in the body, water follows it, raises blood pressure. All right. But I made a point in the last video of telling you that the extracellular fluid compartment, that is this compartment that we take a sample of when we draw a blood test, right? When we draw a blood test, we draw it here from the plasma. But it is only a representative, it's a small representative of the extracellular fluid compartment, and it's only about half the size of the intracellular fluid compartment. And let's look at the difference in concentration of sodium and potassium. In a blood test, your patient should have a sodium level of about 140 and potassiums of 3.5 to 5.1. So let's just say 4, okay? 140 versus 4. So that's that's like 35 times as much sodium as there is potassium. Of course, people think there's more sodium standing here, but there's not. Look at the intracellular fluid compartment. In the intracellular fluid compartment, it's mostly potassium, right? So we're going to talk about how not keeping this in mind actually leads medical professionals to make decisions that end up killing their patients, including someday you will be an experienced PA or nurse practitioner or RN, and if you're not watching that young doctor that's taking care of the diabetic patient, he may kill someone because he's not keeping this in mind, okay? The danger zone when potassium goes above 6, right? Whereas sodium had to go above 150 to get dangerous. This one just has to go above 6. You can see how difficult it is to keep at the front of your mind. So we left off here that sodium was the most dangerous of the electrolyte imbalances. Hyperkalemia. Honestly, the most common cause of hyperkalemia is a badly drawn blood sample or a badly processed blood sample. Why? Because all of the cells that are in that blood sample, they're filled with potassium. So when the blood sample is drawn, if it's drawn in a way that breaks a lot of red blood cells, or if it wasn't handled carefully in transport, some of the red blood cells pop. It doesn't take many of them to pop that you get a dangerous level of potassium in the plasma, even though the patient is fine. So whenever you see a high level of potassium, you always have to stop and think, could this simply be a problem with the way the blood was drawn? But after that, one of the most common ways that you get hyperkalemia is with a crush injury of a patient. If a patient is trapped in a car after a car accident, and their legs are being crushed and they got to be released by the jaws of life, or if something heavy fell on a construction worker and their legs are being crushed, before it gets lifted off of them, then that can cause hyperkalemia. But here's the thing. While there still is whatever that heavy thing is on the construction worker, and the paramedics are with him, he may be talking on the phone to his wife. He's not in much pain because the paramedic gave him something for pain. And he's talking to his wife. But as soon as the weight is lifted off his legs, then all of the blood that was trapped down there will pick up the potassium that's leaked out of the crushed cells and rush it to the rest of his body, and it'll stop his heart. That is, and it'll happen almost instantly. As a matter of fact, paramedics are ready for that to happen, and they've already done some things for the patient to try and keep their heart from stopping. If the concentration rises quickly, it'll cause an abnormally excitable heart. It'll cause a cardiac arrhythmia, and that can kill your patient. If it's happening slowly, it can get quite high and your patient seems to look okay. Now, you probably would see an abnormality on their EKG, but if it comes on very slowly, very often because of vomiting or diarrhea, or there's an endocrine problem that can cause it, and it will make it so that the nerves and the cells become less excitable, and that creates muscle failure for an opposite reason. Okay, so hyperkalemia, slow or fast. Hypokalemia. Chronic vomiting and diarrhea is the most common cause of this, and this generally will lead to the muscle weakness that you feel when you've had the stomach flu for a couple of days. It's not mostly dehydration. A lot of it is low blood potassium. Okay? Now, I keep warning you that you can kill people this way. Let's go back to thinking about nerve cells, okay? So the amount of potassium that's in the cell is meant to have a lot of potassium inside, not very much potassium outside. That's because of the sodium potassium pump, and then we're talking about resting membrane potential. If there is a lot of potassium outside, it's hard for the cell to pump enough potassium to release enough potassium out of the cell. So there ends up being too many positively charged ions in the cell. And you'll look here, you'll see that when there is hyperkalemia, the resting membrane potential for cells is a little bit higher than it should be. So there's less of a distance between resting membrane potential and threshold. So all of these cells, nerve cells, muscle cells, heart muscle cells, become hyperexcitable. When there's not enough potassium out there, then too much potassium wants to leave the cell, and that will make the inside relatively hyperpolarized, and it would take much more graded potentials to get that cell to the moment of threshold. So that's one of the problems. Now, let's talk about acid-base imbalances. Probably the most dangerous situation that you will bump into in the ER regarding potassium will either be crushing injuries, and we kind of talked about that. Crushing injuries, the potassium levels, people are looking for that, generally speaking, or they should be. Okay, but here's the one that will sneak up on people, acidosis. Who are the patients in your ER that are most likely to have this problem of acidosis? The problem of acidosis is probably most common in patients with uncontrolled diabetes mellitus. That's probably most of them. After that, patients that have got a poisoning of some kind of an acid, like a patient that has deliberately swallowed a whole bottle of aspirin, that can cause an acidosis. Overwhelming bacterial infections can also cause a bad acidosis. When your patient has an acidosis, as the hydrogen ions go into the cell, they push potassiums out of the cell. Now, I want you to notice that in this situation, acidosis, too many hydrogen ions went into the cell, pushed the potassium out of the cell. I want you to notice that the patient, overall, the patient still has a normal amount of potassium. It's just the potassium's not in the cells where it belongs. So when patients have an acidosis, because they've got uncontrolled diabetes mellitus, they're in that diabetic ketoacidosis state, their blood test shows really high levels of potassium. And as soon as you give the patient some insulin to start treating their sugar diabetes, insulin will encourage the potassium to go back into the cell. And as soon as you give the patient insulin, the insulin begins to control the acidosis, and you're giving them fluids to control the acidosis. And so correcting the acidosis causes the potassium to go back inside. Here's what young doctors, or those guys that are actually in the 4th year of medical school, but you still call them doctor and they're still your boss. Here's what they forget: that you can, with treating a diabetic ketoacidotic patient that has some hyperkalemia, when you give them insulin and you correct their acidosis, you can make the potassium go away so quickly that you can cause a sudden hypokalemia that stops their heart. Probably at least once a week in the United States, a diabetic ketoacidotic patient dies, very often children die because of this, just because people are not looking for this. So here's like one lesson, if you can take it away with you, please do, that whenever you're looking at potassium levels in a patient, you always must be looking at them with their acid-base status in mind. If a patient has got hyperkalemia and acidosis, they don't really have hyperkalemia, okay? If a patient has got acidosis and their blood potassium levels are not super high, that patient is actually in need of potassium. And little Mr. Young new graduate doctor will go, no, the patient doesn't need potassium. Look, it says right here, normal levels of potassium. But you will know that if there's acidosis and normal levels of potassium, as soon as you correct the acidosis, you will create a critically low level of potassium, and that will stop the patient's heart. Okay? So always when you're thinking about potassium levels in a patient, you need to be thinking about their acid-base status. If you don't take that into account when you are evaluating how much potassium they need in their IV fluids, you'll end up killing patients. Okay? So don't do it. A patient with normal blood potassium, but who also has acidosis, that is a critically hypokalemic patient. This happens with diabetes mellitus patients, particularly those who have been vomiting. If you don't keep correcting their potassium levels as you correct their diabetes and their acidosis, you'll kill the patient. So don't let it happen. A final, just a recap slide. What regulates the reabsorption of sodium? Aldosterone increases sodium retention, but increases potassium secretion. Atrial natriuretic peptide does the opposite. One more thing, a thing that seems obvious to me, but when it's on the exam, I realize it's not obvious. Where does urine come from? It's essentially coming from your blood volume. When you make a greater urine volume, you will cause blood volume to decrease. If you stop making urine volume, you will cause blood volume to increase, right? So the more urine you make, the lower your blood volume. The less urine you make, the higher the blood volume, right? So just in case it's not obvious, I wanted to make it obvious. I guess that's the end of urinary physiology. And for those of you who are in spring 2019, that's the end of the subject matter that will be on the final exam.